Welcome back to Pharmacology, where we will look at drugs affecting the blood. We'll be particularly interested in warfarin as an anticoagulant and aspirin as an antiplatelet agent, but we'll also introduce some other antiplatelet drugs. You'll have to review hemostasis, which is the normal body process whenever there is any blood loss to prevent any further loss. And we'll see that it's the inherent nature of blood vessels once damaged to go through vascular spasm using their smooth muscle. We'll then look at the events that lead to platelet plug formation and then blood clotting to stabilize that platelet plug. So the necessary production of these fibrin threads that contribute to the clot. But what we're going to be most interested in is pathology processes where there is no actual damage to blood vessels from injury. So from without, there may be injury to blood vessels from within. It'll start with the endothelial cells. It might be because there is blood stasis or a disorder in the blood vessels where there is spasming. Another important disorder will be where atheroma form on the endothelial cells, so fatty plaques. This then leads to hardening of those arteries, so atherosclerosis. And these plaques are often, with time, not stable. They will fissure, which is split. They will rupture and therefore bleed. There will be thromboemboli, travelling clots, which we'll see can affect many tissues, including the lungs. We'll look at one pulmonary condition shortly. If ever there is this inappropriate blood clotting process and it continues unchecked, there are a range of disorders where this could then lead to occlusion of those blood vessels, totally blocking the blood flow to those tissues, resulting in many disorders, all of them characterized as ischemic disorders, and this leads to tissue death. Now, what we also want you to preview the physiology of by using any physiology textbook is the way that wherever there is collagen fiber exposure, platelets adhere to those fibers. Usually there might be some tissue injury where the blood vessels have been damaged, but as you can see here, there's no bleeding. It's been some internal damage to those blood vessels that has exposed that collagen. Once that collagen is exposed, you can see that the platelets are marginalizing themselves. Their membranes change. They become quite sticky and they adhere to each other. And when they adhere like this, it causes them to release thromboxane A2. We're going to be very interested in how that mediator is made when we look at the role of aspirin. One of the other important mediators that platelets manufacture and release at the time when they become quite adhering and sticky like that is adenosine diphosphate. And with these two mediators, other platelets circulating by have a change in their behavior where they become aggregable as well, and the platelets do that sticking reaction, activating new platelets to keep increasing the mass of that platelet plug. But that plug will be quite unstable unless it's reinforced by fibrin, and so manufacture of fibrin depends upon activation of an enzyme, and this enzyme cleaves fibrinogen into active fibrin, a process that also needs clotting protein 13 to be activated as well. Now, one enzyme activates another enzyme, which activates another enzyme, and as you can see, because you have studied the nature of enzymes, this leads to a great cascade, because you only need a small amount of enzyme to cause a reaction, and if you keep activating more and more of that enzyme, you get a rapid increase in that whole process, so the activation of the fibrin threads. But the enzyme that sets off this fibrin formation, prothrombinase, can be activated by active factor 10 made in the liver, but active factor 10 can be made by two different pathways. The commonest will be the extrinsic pathway, where there was some damage to the blood vessels, but we're more interested in the intrinsic pathway, where there has been some process exposing collagen from the underlying tissues in those vessels, and this has set off the intrinsic clotting pathway, so make sure you review both pathways. So we'll first of all look then at antiplatelet drugs, where we said aspirin will be the one you're most likely to come across that your clients are on if they're also seeing you for assistance with lifestyle factors post-myocardial infarct. Aspirin is not the only antiplatelet drug, and so we have the whole process summarised there, from when a person might experience a ruptured atherosclerotic plaque right through to aggregation of platelets. And remember, adenosine diphosphate was one of those important mediators. Well, there's a couple of drugs mentioned there, ticlopidine and clopidogrel, that will inhibit the release of that ADP. There are other drugs that affect thrombin and inhibit its actions, and you'll note they have a common ending, irudin. There are yet other drugs that affect the glycoproteins that make platelets adhere to each other. Drugs that antagonize these glycoproteins will then also make platelets less aggregable. There are many drugs of this type. Here's one of interest because it's one of those monoclonal antibodies, abciximab. But we're interested in aspirin, quite a common antiplatelet agent that is used. Note that aspirin reduces the production of thromboxane A2 by its usual action that we've talked about briefly before, how it inhibits COX enzyme, cyclooxygenase. In platelets, this enzyme is irreversibly inhibited. This means that the bone marrow has to manufacture new platelets that weren't exposed to that dose of aspirin before you get platelets that then have that aggregability again. If a person has then had a myocardial infarct and is on aspirin long term, then they'll be on much lower doses of that aspirin because it has irreversible actions and a long-lasting action. The way to remember this, if you are a blood donor and you have taken aspirin, you can't donate blood for about a week. They want to make sure that you have produced some platelets from your bone marrow that are unaffected by that dose of aspirin that you've taken. But people who may need to take aspirin long term and in low dose because they have some thromboembolic disorder, it might be that they have transient ischemic attacks, TIAs, which we'll see is in the CNS. And these TIAs put people at a greater risk of stroke. They may have other thromboembolic disorders. They may have just had surgery on heart valves, where they are then, in addition, also on anticoagulant therapy or antiplatelet agents. Aspirin and other antiplatelet agents do have adverse effects, certainly if they affect cyclooxygenase enzyme levels. And so we'll see that they are used as analgesics in session 6, but one of the adverse effects, because of the inhibition of prostaglandin synthesis, is gastrointestinal distress. And then later, when we go on and look at disorders of the gastrointestinal tract in session 8, we will look at how aspirin can contribute to some quite serious GIT problems. There are many anticoagulants. Warfarin is given orally, and many of your clients will be on warfarin because they are community-based clients. There is parenteral heparin, which you will recall the route of administration is other than by the mouth and generally involves injection. These people might be on this anticoagulant therapy to prevent blood clots from forming because they are post-myocardial infarct, and it's prophylaxis, a preventative medication. Also, your clients that are on these anticoagulants, particularly warfarin, might have atrial fibrillation. The pulmonary disorder that I mentioned, pulmonary embolism, where they have this thromboembolic disorder, a travelling clot that could lodge in their lungs. Also, people with any kind of coronary occlusive disorder, where we saw that that leads to ischemia in a whole range of tissues, might also prophylactically be on these anticoagulants. And it's important to note that anticoagulants do absolutely nothing for pre-existing clots. You need to also, when you review the physiology, look at the process by which clots are dissolved, because you would see when you review the physiology that that's a normal part of the healing process, that dissolving of the clot. Well, here we will need separate pharmaceutical agents to dissolve pre-existing clots, because these anticoagulants, including warfarin, have no effect on clots that have already formed. They are only prophylactic at preventing any further blood clotting. So warfarin, as we said, the prototype agent, generally the drug of choice where there's any medium to long-term anticoagulation for clients out in the community. There's one of the brand names, Coumadin, telling you that warfarin is a coumarin. And when you research it, you will look for other herbs that might contain coumarins, chemicals similar to warfarin. And these coumarins are also analogues of vitamin K. Vitamin K is necessary for the synthesis of many clotting factors, so warfarin, being similar to vitamin K, inhibits the synthesis of those clotting factors. Of all of the clotting factors, factor 7 depletes the quickest. The others follow somewhat later, so there may be a day or two before you get full anticoagulation activity of warfarin. Clotting factor 2, which was prothrombin, is also decreased. But clotting factor 10, which you saw was activated by both pathways, and clotting factor 9 is also reduced because it is one of those vitamin K dependent clotting factors. But note that the other clotting factors are synthesized as normal, so it is completely wrong to call warfarin a blood thinning agent. Your blood is actually in no way thinner once you're on warfarin therapy. What is different about your blood is that it is anticoagulable. It's important that you use the correct terms with your clients, because it can cause some rather strange and misleading interpretations. If you tell them that their blood is thinner, then they panic about traveling, not so much in the plane, but while they're hiking and moving around at high altitude. They think that somehow they won't get enough oxygen because their blood is thinner, and that's not the effect of these drugs at all. It's on manufacture of clotting proteins, and so they don't fully understand when they then have dietary controls and controls over the levels of vitamin K when you use this conflicting term, blood thinning. So important to help them understand the adverse effects and other changes while they're on warfarin by using the correct term. If you're on an anticoagulant, then generally the adverse effects are exaggeration of that main effect. So you'll recognize that as an ADR type A, augmented. So they may bruise easily. Because of small bleeds in the gastrointestinal tract, there may be nausea, vomiting, cramping, and so on. The drug itself might cause diarrhea. It does cause a mild loss of hair, and some people could show mild allergic reactions, rashes, itching. So the more serious reactions of warfarin are where it interacts with foods or other drugs to have enhancement of its normal anticoagulation effects. And so if there's any serious abnormal bleeding, unusually persistent periods in a woman, or blood in stools, vomiting up of blood, epistasis, which is nosebleeds, it could have adverse effects wherever there was a brain hemorrhage, so we'll see controls around its use in people who may have just had a stroke. And of course, if there's any serious allergic reaction, generally the person will be put on some other anticoagulant other than warfarin. So there's warfarin. It has many drug interactions. Some of these increase its effects or decrease its effects, and so you have to check with many of the herbal remedies that you'll be putting your clients on for whether they increase the effects of warfarin. Medications such as St. John's wort, ginger, garlic, or donkai. Ginseng decreases the anticoagulant effect of warfarin, so you just have to look it up and know. As we said, warfarin, one of the commonest anticoagulants used for medium to long-term therapy wherever there is a risk of thromboembolic events, but it would be used with caution in people who did have hyperlipidemic conditions or were hypothyroid, also used with caution in the elderly. Certain cases where you would avoid it, and we indicated any cerebrovascular accident, certain other conditions such as uncontrolled hypertension. You would get that hypertension under control before you gave an anticoagulant. If a person, of course, was deficient in vitamin K, then you would also avoid, but also vitamin C. And because of effects in the liver, that's the site where it has its action, and where metabolites are excreted, you would also avoid in severe liver or kidney impairment. Heparin is the drug of choice if a person was pregnant in early stages of pregnancy, but you tend to avoid anticoagulation for a person who's in late pregnancy in case there was any bleeding that you would want coagulation during the birthing process. Now, one of the reasons why you will have to help your clients understand their warfarin therapy and be working with them is that need for regular monitoring while they're in the community and taking warfarin. There are so many drugs that interact with it. There are so many herbal medications and changes in body circumstances where you just need to monitor levels of warfarin to make sure that the levels of prophylaxis are appropriate. And so the test that's needed is this International Normalized Ratio, INR. You don't need to do the INR with heparin therapy. You need to do a different monitoring test. The INR actually measures the extrinsic clotting pathway, but it's still a way of checking on the levels of warfarin if they are appropriate. Warfarin is discontinued 48 hours in advance of any sort of elective surgery, but if the person had a traumatic accident and it became apparent in emergency that they were on warfarin, then they would also be taken off it as soon as possible. Heparin would be given instead if it was elective surgery. It has a very short half-life compared to warfarin, which has a much longer half-life. We can reverse the anticoagulant effect of heparin. There's an antidote. The antidote, of course, for warfarin is also readily available. It's vitamin K, seeing as that's the clotting coenzyme that the warfarin antagonizes. It does so competitively, and if you increase the levels of that vitamin K, you overcome the competitive antagonism. Mild anticoagulation is sometimes appropriate if the person is having a surgical procedure. Once again, you want to have one where it's readily reversible and where it is controlled. We want to avoid a potential disaster of any excessive bleeding, but just to have a mild anticoagulation as appropriate. If there was a spontaneous hemorrhage in a person who had had an elective surgery but needed to take some sort of therapy because their blood was very coagulable, then there are well-defined guidelines for reversing that hemorrhage. You can give vitamin K. It can be given in fresh frozen plasma concentrates that also contain clotting factors to lead to an immediate clot. So that might occur if a person had a major accident and was on warfarin and was then having a major bleed. They may need to implement this vitamin K reversal. But we did indicate that anticoagulants, even our antiplatelet factors, our agents that stop platelets from adhering and aggregating, have no effect on already formed clots. Here you need an enzyme that will dissolve the clot. So we have various drugs, all of them end in PLAs as an indicator of their action as thrombolytics. In myocardial infarcts, they might give a drug, streptokinase, which will immediately dissolve clots and prevent serious ischemic damage to a person's heart. The problem with these, they come, in the case of streptokinase, from a bacterial source, so they're foreign to that person and they will make antibodies to that streptokinase. Hopefully their myocardial infarct risk will be stabilised and they won't have any further MIs, but if they do, then they can't be given streptokinase again because it will be totally ineffective at dissolving the clot due to those antibodies that the person will have made. So you've always got to be giving them a different kinase drug to dissolve serious clots in the heart and in the coronary vessels. So the action is to dissolve the clot by that endogenous fibrinolytic system. The ones that end in PLAs convert plasminogen to plasmin, and plasmin is that endogenous system of digesting clots. Thrombolytics, of course, will then have as their adverse drug reaction an augmentation of that main action of dissolving clots. It could lead to serious bleeding. Because many of them are proteins, they can cause headaches, and they can also collect in glomeruli. You can often have quite severe headaches, blood in stools and urine and so on from their dissolving actions on clots and then leading to bleeding again in the gastrointestinal tract or similar sites. Also, these thrombolytic agents will interact with anticoagulants and antiplatelets to increase the risk of hemorrhage, even though these don't act at existing clots. The two act in a similar pathway, and so you'll get this pharmacodynamic interaction. Thrombolytics are contraindicated, as we said, if one has already been given and the person might have raised antibodies to it. Also, once again, to limit any further damage in the CNS, they are contraindicated in people who might have just had a stroke, a cerebrovascular accident. They are also avoided in surgery, hypertension, and if a person has active internal bleeding.